Hello and welcome, everyone. I am Stephen Collins, the CEO of Matter. And today we're going to be talking about a new report that the Peterson Health Technology Institute has released on virtual solutions for opioid use disorder. Matter's mission is to accelerate the pace of change of healthcare. We run an incubator for healthcare startups. Over the last 10 years, we've incubated more than 1,000 companies from around the world that have raised more than $5 billion. We also run 6 or 7 startup accelerators each year. They're cohort-based programs that we develop in partnership with large health systems, life sciences companies, payers, associations, universities, and foundations. We work with large enterprises to help them build their innovation capabilities in a variety of ways. And we recently launched an AI bootcamp to help teams quickly figure out what are the right use cases for generative AI. We are also the digital health hub of BARDA, the arm of the Federal Department of Health and Human Services, responsible for developing solutions that will better prepare the US for public health emergencies. We have 3 programs running right now, which include substantial amounts of funding available to companies to help them validate their technologies. If you're interested in that, you can find more information on our website. We host many conversations with thought leaders on different topics, and I always enjoy talking with Caroline Pearson, who runs the Peterson Health Technology Institute. The Institute provides unbiased, independent evaluations of digital health technologies, and their most recent report, as I mentioned, is focused on opioid use disorder. The opioid crisis remains really a tragic failure of the US healthcare system. There's more than 100,000 people who die every year from overdoses. Roughly 75% of Americans with opioid use disorder don't receive medication-based treatment. Very complex landscape. There's provider shortages, regulatory barriers, there's stigma issues, fragmented systems of care. And a number of virtual care companies have emerged to close that gap, that promise to make treatment easier to access and stigma-free. And the question that PHTI was tackling, and that we'll get into today, is whether they're delivering on that promise and what the trajectory could look like. So if you've read the report, or you'll have a sense of the direction, but we'll hear directly from Caroline. She'll provide an overview of the report, and then we'll have a conversation about it. If you have questions at any point during her presentation or during the Q&A afterwards, please use the Q&A function, and I'll do my best to weave your questions into the conversation. And with that, I want to welcome Caroline Pearson. Thank you so much for joining us again. I always enjoy your presentations and our conversations, and look forward to your presentation now.
Thank you so much. Well, always good to be here. I tell Stephen every time he asks some of the best questions that I get anywhere, and so we love that dialogue. And happy to be back. So very excited to share a bit more information about our recent assessment. It came out in mid-September, and it really did focus on these sort of virtual care solutions and wraparound solutions for treating opioid use disorder. Just a reminder, as always, all of the details are full assessments, executive summaries, and materials that are directly for patients as well as for policymakers are included on our website, so you can get everything there at phti.org. And just to give you a brief reminder about how we do this work and how we conduct our assessments. First, we have to pick categories to focus on. And we are always looking for areas that have significant disease burden and that generate high healthcare spending. Relative to some of the other PHTI reports, the OUD is a much smaller prevalence condition, but given the serious impacts of the opioid epidemic and the very significant health and potentially fatal consequences of the disease, we really did think that this warranted a more in-depth examination. We are also always looking for areas where there's been a lot of technological innovation. So you have digital health companies coming forward with new ways to engage and treat patients, whether virtually or through digital applications, and strong evidence with which to make an assessment. So that is how we pick our topics. And then, as Stephen mentioned, we're really looking to assess based on two core questions or core areas. One is clinical effectiveness, and the other is the economic impact of the solution, with an effort to answer these three questions. Do the solutions work? For whom? For which patient populations? And if so, are they worth it in the scheme of a healthcare system where we're balancing lots of trade-offs about what to cover and pay for? We do very rigorous and detailed analytic work, all of which is included in our reports. But then we try to synthesize our findings into clear recommendations for healthcare purchasers, specifically for health plans, employers, and health systems that may be making decisions about adopting these solutions. And we try to give them guidance about where there are categories of high potential and where we may need more evidence generation or progress before we invest a lot more resources. We have a lot of stakeholders that work with us throughout this process. Before we begin reports, we work with our Purchaser Advisory Council, which is sort of our voice of customer. We don't have any customers that pay money, but we certainly want to create information that is actionable and relevant to decision makers. And so we meet with those decision makers regularly to know what is top of mind for them and what their information gaps are that we are seeking to fill. Within our assessments, we have a number of assessment partners. We recruit clinical advisors specific to each of the categories of solutions that we're looking at. And then we do direct work with patients, direct interviews with patients to understand both their experience in the traditional or usual care environment, as well as the opportunity and effect of digital health solutions on that care. And then finally, we work with the companies themselves. No companies are required to participate in our assessments. Whether or not they participate doesn't affect their inclusion in the report. But many of them do choose to participate, and they get to share information with us about their business model, their commercial approach, and any additional evidence or pricing information that they think would be helpful to our assessment. So let's dive into this particular review. So as Stephen mentioned, the OUD epidemic continues to grow, and unfortunately with the growth of fentanyl, remains very fatal in this country. More than 9 million adults in the US suffer from opioid use disorder. And though estimates fluctuate, about 80,000 deaths are ruled as opioid involved on an annual basis. The standard of care, which has been proven to be the most effective care in delivering long-term treatment, is medication-based treatment, typically using either methadone, buprenorphine, or naltrexone, and a combination thereof. But unfortunately, as you see on the right, only 1 in 4 people who have opioid use disorder are receiving this standard of care using MOUD treatment. Another 30% are receiving other treatment, maybe abstinence-based treatment or other care that is not including medications. And 43% of people with OUD not only do not receive any care, but do not perceive that they need treatment. And so that untreated population is a core focus of the opportunity to improve outcomes on this disease area. Of course, not only is the human burden of this very important, but the economic burden is significant as well. We are estimated to spend about $175 billion annually, both in healthcare treatment costs as well as criminal justice and other spending. So when we dug into virtual OUD solutions, we wanted to look at what this category of companies has been delivering. And these companies are not new. Many of them have been around for about 10 years. And generally, they include different combinations of medication prescribing with other support services. So as we described at their core, MOUD, or medications for opioid use disorder, are the basis for most of these treatment programs. They are typically buprenorphine based because most of them are outpatient and, at least in part, virtually administered. And they can conduct virtual evaluations, write prescriptions, and even in some cases deliver those prescriptions by mail. And that really saves folks from a lot of the sort of in-person, multiple times a week outpatient visits that are necessary, adding a lot of convenience to something that's a relatively intensive outpatient treatment program normally. These solutions also include a combination of the digital support services that you see here on the right. Many of them include virtual therapy programs. Some of these solutions even partner with some of the virtual mental health apps that we looked at in our last report. They also include libraries of digital content and educational material, as well as virtual peer support groups and care navigation services. Importantly, many of them also include approaches to virtual drug testing and contingency management, which is a term that is new to our reports and is really specific to substance use disorder treatment. And this is really a reward system, often a sort of points-based or monetary reward system that encourages people to remain active and adherent to their care plan. And this is a core piece of some of the solutions that we're going to be looking at. And again, is really meant to increase the adherence and retention to care. So our assessment included 16 different companies, which we grouped into sort of two main categories. They are similar in their final experience as a patient, but their business models are somewhat different. So what we call the medication-focused solutions are really comprehensive medication-based virtual care programs that are prescribing buprenorphine and other drugs and offering additional virtual support programs, which may be some combination of what we saw in the last slide: therapy, peer support, or contingency management. And those programs are meant to be a full replacement for other in-person OUD treatment that people may be receiving. So these are sort of comprehensive care, and they're not additive to, they would replace other treatment options. On the right, you see the digital wraparound solutions. These are providers that are really building those digital support services, the tools that we saw on the right-hand side of the last slide, and enabling those to be paired with other in-person or traditional MOUD providers to offer a more comprehensive care experience. So you might go in person to receive your buprenorphine treatment, and your provider might be partnering with one of these digital wraparound solutions to offer your contingency management benefits, for instance. But they do not include the prescribing as part of the digital solution. Now, in any of our reports, we have to think carefully about what is the most appropriate outcomes to be measuring. And we always look at a large range of outcomes and all of the outcomes that are described in the clinical research. But we do work with our clinical advisors to select a primary outcome. And in this case, the selection was very clear. All of the experts in the field instructed us that retention to medication-based treatment is really the primary outcome that they are looking for, as it is most predictive of treatment success over the long term and overdose avoidance. So people who stay in care are less likely to overdose and more likely to be able to remain in recovery. We also looked at abstinence and relapse rates, which are some studies do report, various safety and adverse events, symptom management, engagement and satisfaction, and other measures of health equity. Our review included about 4,000 articles, posters, and abstracts. And as we got into that, the assessment was really grounded in 43 core studies that include both real-world evidence as well as RCTs and company-generated data. So what did we find? Well, first and foremost, when we look at the clinical effectiveness, we see that patients that are using virtual OUD solutions generally had comparable outcomes as usual care. And I want to pause there because that is really important. Actually, historically, folks did not believe that opioid use disorder was something that could be treated effectively via telemedicine or via virtual care. In fact, prior to the COVID pandemic, there were many policies in place that made it very challenging to deliver comprehensive care on a virtual platform. And what we have seen in the evidence is actually that these programs translate very, very capably to virtual environments and can be clinically effective on par with usual care. We did see, you hope that you're going to have higher treatment retention as a result both of the convenience and reduced stigma associated with virtual platforms, and also some of those support services that we talked about, contingency management and other therapy benefits. Across all of the evidence that we looked at, we found that on average, after about 6 months, the virtual programs had about people in the virtual programs had about 13 days longer treatment retention than individuals receiving traditional usual care. So you do see a modest improvement in treatment retention, but not something that is perhaps as material or significant as we might have hoped to see. Now, I will point out that experts remind us that in recovery, every day matters. And importantly, on any day that somebody falls out of treatment, they are at higher risk of overdose. And so, I think some of the clinical advisors really did feel like 13 days was a meaningful step in the right direction. Yet, I think we can all look at this and realize that we have far ways to go in terms of really improving the outcomes for folks with opioid use disorder. The second piece of our clinical effectiveness review was really trying to look at changes to access. So we have talked a lot about the fact that people with opioid use disorder face a lot of stigma. There are many geographies that do not have treatment providers, pharmacies that don't want to stock medications and buprenorphine, and a lot of social stigma that prevents people from seeking out care. And so you hope that virtual care programs that can address some of those barriers would be able to improve access to care and actually bring more people into treatment. We worked directly with each of the companies in our assessment to collect data about their patient mix. And at this time, we did not find evidence that these programs are reaching materially more untreated patients than usual care programs. And so I think that's really an area that we should dive into in terms of future opportunity and how we can continue to use virtual care programs, which are effective, to expand treatment coverage and access. Now, as we look at the economic impact of these solutions, we need to look by category. So the medication-focused solutions, those are the comprehensive programs that we talked about. They are really being used as an alternative to usual care. And interestingly, they are generally priced and reimbursed in the same way that other OUD treatment is provided. So you see that they are generally accepting case rates or fee-for-service reimbursement on par with typical OUD care. And given that they perform comparably, on a sort of same clinical effectiveness basis or a little bit better, they do come out in terms sort of neutral in terms of budget impact. Meanwhile, the digital wraparound solutions are generally being sold and reimbursed separately from traditional OUD care. And those solution prices, while modest, outweigh the expected savings from the 13 days longer treatment adherence. And so they slightly increase overall healthcare spending. So if we look at our stoplight graphic that summarizes all of this, once again, we see that on clinical effectiveness, both categories are generally effective though the evidence quality is somewhat stronger for the digital wraparound solutions. Um, and you see the economic benefits are basically almost budget neutral for medication focused and a slight increase for digital wraparound, which means that we do recommend increased adoption of medication focused solutions because they can be substituted for usual care. But we do urge that there needs to be a real focus on how to ensure that those programs are not just replacing other usual care, but really bringing more people into treatment and closing some of those access gaps, particularly in geographies where there may not be treatment providers available. In terms of the digital wraparound solutions, if they are being reimbursed separately from other OUD care, we would really want to see stronger improvements, clinical improvements in treatment retention to justify the increased cost of those solutions. So where does that leave us in terms of recommendations? So first, we are an evidence-based organization, and so I think on all of our reports, you're going to see that we would like to see stronger evidence generated across all of these categories. And one of the particular areas that we would like to focus on is which of the digital support solutions are delivering the greatest impact. Unfortunately, much of the evidence kind of combines multiple support services, and it's hard to parse the individual benefits of any one solution. For instance, while there is actually relatively better evidence about contingency management, and we know that that may be particularly useful for people with stimulant use disorder or for the many people suffering from co-occurring substance use disorders across multiple types of addiction. It would be helpful to know which support services should we be guiding which patients to, in hopes that those are really going to demonstrate stronger improvements in treatment retention. We also don't have great evidence about subpopulations and whether we can better target specific types of interventions to the different kinds of patients, whether that be based on demographics or based on their substance use history. Second is really to focus on expanding access. And of course, this is something that all of these companies want to do and continue to pursue, and we see variation across the body of evidence. But we need to be focusing on patient acquisition and engagement to bring more people into treatment. And what's interesting here is that this is really something that I think is facing the entire digital health community. We can build great virtual and digital care platforms, but the act of bringing someone to those platforms, finding the patient in their recovery journey at the moment that they are willing to initiate treatment, that is often something that requires partnership with providers, community groups, and other organizations that can help refer people to effective virtual care programs. And so thinking about this more holistic integration of digital care and digital solutions into our usual care environment is going to be really critical to future success. Number 3 here is to think about improving care coordination, and this begins to address what I just said, which is you've seen a lot of innovation and pilots in the substance use disorder community, things like programs set up in emergency rooms and other unique partnerships where we try to create opportunities to bring people into treatment in the places where they may be spending time and engaging with people. And we need to continue to do that in terms of thinking about recovery solutions as well. Number 4 is really leveraging the opioid settlement funds to support some of these solutions and other evidence-based treatment options. The opioid settlement funds, there are not many places in healthcare where there are pots of available money. Many states and localities do have opioid settlement funds available to them, but unfortunately, there is relatively limited coordination and guidance to many of the people responsible for directing those funds. And I think greater awareness about the effectiveness of virtual OUD solutions and how funds might be able to support that treatment would be very valuable. And then finally, continuing to modernize federal and state policy. I will say this has come a long way. COVID pushed a lot of things forward on the federal and DEA policy environment. The shutdown and delays in extending teleprescribing rules is not among them. And so I think finalizing existing teleprescribing rules and then beginning to think at a state level about licensure flexibility is going to be incredibly important in order to help some of these companies grow and scale across state borders in ways that are going to be, thoughtful about resources and expanding access, regardless of sort of workforce distribution. And so with that, I'm going to stop sharing and welcome Stephen back to the Zoom. And I look forward to getting into the questions.
Well, thank you so much. It's such an interesting topic and is particularly nuanced, as I think anybody listening to what you were saying would pick up. So I'm just going to jump into, I have like 50 million questions and we don't have time for 50 million questions, but I will start. So one of the things you mentioned that, at least in your tone of voice, it almost sounded surprising, was that the virtual solutions were just as effective as in-person, the virtual medication solution, just as effective. Should we be surprised by that? Is that something that you've seen in other areas? Is it unique to this space, or is that just, telemedicine works?
Yeah. Well, I think it depends on your point of view. I think my sense is telemedicine works for certain things in certain contexts. And we shouldn't assume that telemedicine is great for everything. I sometimes tell the story of my whole, trying to do a mole check with a dermatologist during COVID. Didn't work so well. But, and I think everyone who's experienced it knows there's things that translate well and things that don't. I think what was striking to me, there were times in this report where the 13 days, we were sort of discouraged, right? You kind of hope that
Yeah.
there's going to be a silver bullet and things are going to get much better. And 13 days felt like modest improvement. And, it was good to talk to clinicians who have worked in this space for so long, who have said, no, like we really felt like you had to see these patients and engage with them and have them come in, and that was all sort of part of the stickiness of the experience. And so to be able to replicate that level of engagement and impact virtually is something to celebrate. And so I do want to underscore that, demonstrating the comparableness of the virtual care is valuable, particularly for people who don't live in digital health land all the time. And so it is a win.
And what 13 days out of what? Like, is this, that they stay in treatment 13 days longer and the normal treatment cycle is 10 days? That would be like, wow, that's huge. What is the
Yeah, so it's something like 136 days goes up to 150 days, or
so like a
crazy math, but yeah, exactly.
10-ish%, yeah. Was there anything that that you saw in all the data that you were looking at that pointed at why that was, and something that therefore the companies that are doing this could really double down on and try to drive further? Or because it's not nothing, 10%, 13, it
Yeah.
sounds like it was statistically significant across what you were looking at, or you wouldn't have reported it the way that you did. So
Yes, it was definitely statistically significant. And the reason I'm hedging is, when you get into it, there's lots of ways that folks measure those days and whatnot. And we've tried to sort of normalize all of it, but it's all in there. I think there's been a lot of work on the digital wraparound component, right? Like, yes, the medications work, they work, as they do, right? Like, that's a pharmaceutical intervention mostly. And so the question is, what can we do with education, peer support, contingency management, to really get people to stay engaged? That's the piece that's moving the needle. And that's really what we saw in the evidence. And so, the question is, it does work. It is sort of a small but significant step in the right direction. And so that's where I say, when you want to dig into the evidence, let's double click, right? For which people? So contingency management, as I mentioned, is a good example. It works really well for stimulant use disorder. And lots of people with opioid use disorder also use stimulants. So that's a good population. It's not clear that it's quite as beneficial for, opioid use alone. Um, these are all different pathways. And then there may be sort of demographic differences within that cohort that we could begin to explore. And so, if people have limited time and limited attention bandwidth, I think we sometimes say, like, let's throw everything that might work at a patient, because let's make everything available. And there's some logic to that, right? But the more we can say, actually, we have better data now, and we know that the thing that's going to matter to you is sitting down in like a live group therapy session via Zoom every week. Like, that's the thing that's most likely to get you to stay. Let's just try to convince you to do that rather than distracting you with all of the sort of extra stuff that we might have available.
Yeah, the segmentation, I mean, there's nothing in my lay brain that inherently says, oh, stimulant use. I mean, so obviously there's more work to be done. But at least like as a signal that's, positive, that it's moving in the right direction. So on the other hand, just the wraparound solutions, not the kind of virtual, we're sort of adding costs, not improving outcomes. Does that, or at least not improving outcomes enough to justify the costs? I don't want to. And so is that, how different are those wraparound solutions from the non sort of medication aspects of what the first category was doing? And how should we interpret that? Is it they that we should not focus on those, or there is a lot of promise there? I double click on that to use your.
Yeah. I mean, so from a patient point of view, actually, both of these categories of solutions would hope that patients are both getting regular buprenorphine treatment, virtual or otherwise, and access to support services that are going to help improve their treatment retention. That's kind of the ideal model. Now, some of the wraparound solutions may be available to folks that aren't receiving medication-based treatment, right? There's lots of configurations. But I think for each of those categories, they'd say our optimal care environment looks very similar between the two. And so it's just a pricing and business model question.
Yeah.
And even there, relative to all of our other reports, the dollar swings, positive and negative, in this one is small. These solutions are relatively low cost. The savings are not huge from 13 days. And so, you can sort of take a step back and say, goodness, if we are a public health agency, if we are a Medicaid program, if we are an opioid settlement fund who is concerned about this epidemic, this is an investment that pays off, and we're seeing progress, and we should keep investing in it. And the added incremental cost is small. And so, that shouldn't worry us. I think that's a reasonable conclusion. At the same time, I will tell you, I've talked about this with large national health plans and for some employers, but let's take large national health plans, and they've said, look, every program that we implement takes time, takes resources, right? Integration costs. These programs aren't moving the needle enough for me to prioritize them relative to everything else I'm trying to do for a generalized patient population. And so I think that's a little bit, it depends on sort of where the money's coming from and where you're sitting. And
Yeah.
employers is sort of a unique one, right? Actually, for a lot of employers, these are not on their radar. And then you talk to certain employers, particularly those where they have a lot of manual labor in their workforce, right? Think airlines and warehouses, and they really contend with this issue. And then certainly geographically, there's some variation. They're struggling with this in their workforce, and so it's a huge priority. We have a representative from BJ's who speaks very openly about the importance of addressing substance use disorder in the workforce, because they understand that it's sort of part of their environment.
And what have you seen in those categories of employers? What are they digging? Are they sort of all in on these kinds of solutions? Are they cautious? What's the range that you've seen? And did you have conversations with any employers who said, oh my gosh, we love this category of thing because it blah blah blah.
Yeah, I don't think anybody, none of these results are nobody's nobody's celebrating
Right.
about our progress on opioid use disorder yet, sadly. But I would say they understand that it is a problem in their workforce, and that some of it is, some of the sources of those diseases are from job related injuries, right? I mean, that's a
Mm,
big issue, is like that's where people are first getting an opiate prescription that becomes an OUD condition. And so they take it really seriously, and at that point they're saying, look, we need to support our workforce, and anything that makes forward progress is important. And so I think they were really pleased to see the results. I mean, it's been hard to, we do these reviews because actually, if you're an employer, it is hard to tell what the clinical benefits of some of these solutions are. And so we actually had some employers who said, gosh, we're looking at OUD solutions now, and we're going to like hold our procurement until the report comes out. And they were really pleased, right? They said, this is positive. Like we now feel confident moving forward with the partners we've been talking to. So that's great. And I think signals the interest in this important area.
yeah, that is really interesting. So I want to talk about access for or switch to act. So one of the things that surprised me was that the virtual solutions did not, the conclusion is they didn't increase access, which is sort of counterintuitive when I think about it. We think about in a lot of areas, there's shortages of, there's either a mismatch of where providers are and where services are and where people are, or there's shortages of them, or both, and that one of the things that telemedicine offers is the ability to kind of smooth out supply and demand and provide more access. And it sounds like that, at least for now, is not happening. And why is that? Is it a technology problem? Is it a policy problem? Is it, you touched a little bit on the reimbursement aspects, and it sounds like that's not the problem these days. So help us understand why.
Yeah. So first of all, I will just say, like, this is an area some of the companies have said, we feel like we're doing better than your report said, and I said, great, please publish, right? We did work directly, and we got a bunch of unpublished data. So we have looked carefully at this to the best of the ability, to the best of our ability with the data available. So based on published and unpublished data, right now, the treatment mix for virtual care providers looks exactly the same as usual care providers in the country as a whole, which means they're a good part of the treatment landscape. But we're not, if you think about that 1 in 4 people getting high quality MOUD care, we're not growing that pie,
Yeah.
right? And so our definition of improved access, increased treatment, right, is growing that pie to more than 1 in 4. And so there's a few things, right? One is making sure that we are focused in geographies where other treatment isn't available. And you do see a little bit of variation company to company based on their geographic footprint. But then two is referrals. So a lot of providers and community workers, like folks that do work in this space, are not that familiar with these companies yet, right? Like as with any digital health company, like it is an emerging part of the market. And so, if you have someone who is talking about starting treatment, is the person that they're speaking to going to say, hey, check out this virtual care program? Do they know it exists? They certainly don't know that that person has coverage for it, right? This is sort of like how do you find a digital solution, and how do you refer if you don't know whether it's covered by your employer, your health plan, or your public health agency? So I think that's a second thing. And then the third piece is the hardest, which is, I told you that the biggest piece of that pie, right? I think 43% of people don't think that they need treatment.
Hmm.
And, that's a huge challenge for providers of any kind. But, that's the sort of marketing's a terrible word, right? But the outreach, the messaging that we need to sort of say to people, there's treatment available, it's easy, it's stigma free, it's private. and give it a shot.
So even if you take that 43% off, I'm trying to remember what there was there was the 25%, there was the 43, there was another big chunk.
Non-medication based treatment.
Yeah. And um what is the is that, if you had to figure out where the real opportunities are, is it convincing people who don't think they need treatment that they do need treatment? Is it convincing people or providing opportunities for people who are in non-medication based treatment that there's some proven alternatives that work? Or is it, did you, I'm asking you, and you may not have this level of segmentation, but is there some sort of like, if we could reach, the biggest opportunity is with this 12% of the population who lives in rural areas and they're just nowhere near a facility, they know, and they're employed by someone, or like, if you slice it and dice it, was there a path that emerged in the data that said that would sort of provide a direction for these companies or for employers or for payers to try to increase the percent of people who have opioid use disorder who are receiving medication treatment?
Yeah. I certainly think in certain industries, like employer coverage and then employer marketing to the workforce is right. I mean, that's like a great channel. And there was like a in-depth news report a few years ago about like a prominent meatpacking company that had done that. Right, was struggling. It was in a geographic area with um, a lot of disease burden, and it was a priority. Uh, that's a good way to reach folks and to tell them there's a solution. The folks in non-medication based treatment is certainly, at least you've got willing patient participants there. It's challenging. The I'm going to call it the fight, but the fight between medication based treatment and abstinence based treatment has been sort of going strong for the last decade or so. Since there's been really convincing evidence that medication-based treatment is far and away more effective. And you still have a lot of people getting not great care. So, in some sense, those patients are ready, but I wish we could convert that group over more quickly. Um, but I think geographic targeting is probably the best place to start. Right, virtual care providers can go to areas where disease burden is high and provider capacity is low, and we know what those areas are.
And are the people who are in non-medication based treatment, who are getting non-medication based treatment, are they um is are the people who are the people in the organizations that are providing that treatment, do they have any incentive to provide medication based treatment? Yeah, I mean, my sense of it is that system is a bit broken when it comes to well, I mean, clearly it doesn't work. I mean, the recidivism rates are like off the charts, but that just the economic model and the structure of it is, that it's just not optimized for really supporting patients through this journey that they need to go on in order to sort of be in recovery long term.
Yeah, I mean, and certainly I'm not the expert on all of the challenges in the substance use disorder treatment space. I think there's certainly providers that continue to believe that medication-based treatment is sort of substituting one addiction with another. That's sort of the old adage.
Yeah.
Sad as that is, there are definitely patients that choose that path also, right? That say, this is what's right for me, and I'm not interested in medication-based treatment. But in most cases, we don't have sort of a comprehensive healthcare led, right? This is a disease. Let's treat it as a disease. We don't have a healthcare led approach to identifying patients and matching them with the right treatment that is going to be most effective and appropriate for their desires. And we continue to treat it as sort of either a criminal justice matter, or, and we're trying to prevent adverse events. I mean, one of the most interesting things to me as I got into this space is seeing the effects of Narcan. So the death data, just the annual overdose rates just grow year over year over year, and then all of a sudden you see this drop in the numbers, the change in trend as Narcan became more widely available, and that was both amazing in terms of improved outcomes. But I think a lot of energy has gone into getting Narcan into the hands of all of the places where people might need it. But I think few of those places also have guidance on how to access treatment and recovery options as well.
I mean, this is, I think every area of healthcare is complicated. This one is more complicated. And you just touched on, I think, a number of those reasons that there's this whole criminal justice I mean, it's just, anyway. All right, different question. So a lot of the people who are affected they're in rural areas, they're in low income areas. I mean, not everybody, obviously, but a lot. And there might be limited broadband access. There might be, did you see uh, anything in the data in the work that you were doing that suggested that increasing, broadband access would be a vector to sort of benefit these companies, get more people on treatment, or was that not a particularly significant part of the reason why people aren't accessing the virtual medication-based treatment?
Um, it's a good question. I mean, I think this question comes up whenever we talk about digital solutions.
Yeah.
And so let me start by giving my general digital solution answer, which is, you know, yes, there are places where broadband access is limited, and I think an important policy effort is to expand that access so that people can continue to engage with all sorts of modern life, increasingly a virtually enabled healthcare environment, right? So yes, we should prioritize that. And you can still sort of say that digital is an important piece of the treatment landscape, even if you don't have perfect internet coverage, right? That doesn't negate the importance. We saw actually higher treatment retention rates in rural areas than in some urban areas. So I think that really speaks to the challenge of access right now. And so like it sort of underscores if you're going to have to travel a long way, even if you have a treatment provider in your county, but your county's big, you can drive a long way, and you start to say, oh, you got to come weekly or twice a week for your outpatient visits. You actually get better adherence in rural areas by eliminating that transportation barrier. So the clinical evidence suggests that it does work well in rural areas, notwithstanding the broadband issues that you raise, which I think are relevant in certain areas for all of our interventions of interest.
Interesting. What about, so on the wraparound services, so obviously you talked to all the companies that are providing these services. You had a dialogue with them. Presumably they had the benefit of the sort of collective wisdom that you aggregated and then provided. But there are a lot of companies. There's a lot more companies in this space than you have the capacity to review in one of these reports. And so what would your suggestion be to those companies? What should they do? Especially I guess both, but especially the kind of digital wraparound services, which a lot of them, they seem like they should work. They're not, it's not like these are, at least, I mean, I've seen a number of them, and it's not like people are making this stuff up. It comes from, really well grounded in what kinds of interventions can be effective. So what's your advice generally?
Well, yeah, I think So there's sort of a clinical model versus a business model question. And
Yeah.
it's helpful to separate them. From a clinical model point of view, the combination of medication and other support services is valuable, right? That's what this report says. And adding those support services increases the retention and is uniquely valuable. So, if we're going to say what does good OUD care look like, it used to be right move from abstinence-based care to medication-based care. I think the future standard of care is going to be medication-based treatment plus support services that include therapy, peer support, and where relevant contingency management. They are effective. With scarce resources, it is hard to figure out how to integrate them from a business model point of view. So I think, from PHTI's point of view, like ideally, you would have an OUD provider that couldn't offer support services, the provider contracting with the wraparound solutions to bring, because they think it's enhancing the quality of their care, right?
Mhm.
But then sort of billing at the standard rate. And we see that in other clinical areas. Because OUD treatment reimbursement rates can be quite low, I think that doesn't always happen, right? And so it is hard to justify the added cost when you're selling them separately. And so you've seen some, I think in fact, like if you look at Resetto, which was Paratherapeutics contingency management digital therapeutic, that was acquired by Pursue Care, which is one of the medication-based sort of comprehensive solutions. And that's where more of the companies is. I think just in the current reimbursement environment, it is turning out that being able to offer that comprehensive care and just manage the costs across both medication and digital solutions is a more straightforward business model right now, with the reimbursement landscape being what it is.
Yeah. Again, I feel like everything in healthcare, we end up trying to figure out a business model for things because of the um it's complicated. So if you could wave your magic wand and change one thing,
Mm.
um, anything, whether it's like reimbursement rates or settlement fund, like something, what would and you that you think uh would actually drive more people to these solutions, what would it be?
Oh, I'm torn. Um, uh, I think realistically, it. I would wish that with every location, whether it be a library or a gas station or a fast food restaurant or a police station that has Narcan, that your Narcan came with like a free enrollment in a medication-based OUD solution. Like wrapped around your like scan this URL or this
Yeah,
QR code and you're in. That would probably be my number one wish. And my secondary one, because I'm gonna take the liberty of saying it, is just the DEA has made this hard for years.
yeah.
And a lot of these companies have been around for years and they're much smaller than other companies, other digital health companies that we've looked at for their age. And part of that is that the policy environment has made it incredibly hard for them to deliver high quality care and scale. And I think the removal of the X waiver, the teleprescribing rules, they've done a lot to make it easier. But those rules aren't finalized. As I said, shutdown threatens them. And so continuing to make sure that the policy environment is supportive of virtual medication-based treatment is really important as well.
So you're thank you. You're working on another report that I think is going to be released early next year, which I think is particularly interesting and relates to both this topic, but also I think this OUD report is your fifth or sixth ones. You're kind of starting to, get across a variety of range of categories. And then the one that's coming out next, I think, is a different category of report. Can you describe what that is and why
Yeah.
we should be excited about it?
Yeah. So in January, we're going to be releasing a new body of work that is really focused on performance-based contracting. So in almost all of our work, we have said that purchasers should be rewarding digital health providers based on their outcomes, not just based on their satisfaction rates or their engagement rates, but really based on their clinical, or in some cases financial outcomes, if that's what the goal of the solution is. And I think there's we just did a survey of purchasers, and you heard many, many employers saying they would like to do more of that. But that it's hard. They have limited staff capacity. And so we have been working with both 50 entities that cross the purchaser land and the vendor land to come up with templates and standard definitions for performance-based contracting that are both general principles as well as specific standards that could be used for each of the reports that we have done. So one for diabetes, one for hypertension, et cetera. And we will do one for each future report that we release. We'll come out with one of those performance-based purchasing guides, with the goal really being that you start that negotiation a little closer together than you might otherwise. And, we smooth the administrative burden of negotiating those contracts and really begin to get a clear understanding that we're paying for results that are proven and that you can see in your own population.
I hope that works. I mean, that sounds great. And obviously it's a new thing and you hope it works too. But, having talked to employers, every one of these is a fresh new thing. I mean, it's not like there's a clear template that they've done 50 times and they can do. And then the same thing on the company side, get questions all the time. What should we ask for? How should we do? And so I think that's very exciting. Well, thank you so much for coming onto our platform again, sharing your insights. I always enjoy our conversations. I hope you'll come back as you continue to release more of these reports. For everyone who joined today, thank you. Matter has a number of in-person and virtual programs coming. If you're interested, you can go to matter.health/events to learn about them all. Thank you again and enjoy the rest of your day.